Hello, my name is Dina Stoneberg, and I am a member of the Temple University College of Public Health Alumni Association's Executive Board and DEI Committee. It is an honor and pleasure to welcome you to this Lunch and Learn on substance use disease and treatment inequalities. Chock full of Temple College of Public Health alumni bring all of their knowledge and expertise back home. The College of Public Health Alumni Association serves to connect alumni back to our college to broaden and enrich the experience of our current students and other alums. Our DEI subcommittee works to provide programming that surveys a wide range of our graduates on relevant topics in subject areas related to public health and social work. We chose this topic because opioids have touched every corner of our community. They have devastated communities close to Temple's main campus. It's hard to find anyone who has not been affected by substance use disorder. Pre-COVID, our city was dealing with the effects of a high level of fentanyl in our heroin. This inexpensive filler drug replaced more and more of the heroin on the street until there was no heroin left. Fentanyl left this vulnerable population even more impacted with higher and shorter highs, resulting in increased use of syringes, more overdoses, and a higher number of unintentional overdose deaths. 2020 was the deadliest year ever for overdoses in Philadelphia. COVID and its spread by close contact fueled our deaths due to overdose because people were more likely to use alone. Today's panel is really a labor of love because this group compromises some of the best that Temple has to offer. Our moderator, Dr. Sarah Bass, is an associate professor in the Social and Behavioral Sciences Department, as well as the director of the Risk Communication Laboratory. Her research focuses on health and risk communication and how public health messages are crafted for diverse audiences to enhance decision-making. She has advanced the field of health communication by applying commercial marketing techniques to the development and testing of messages or interventions. Sarah serves as the Vice President of Prevention Point Philadelphia's Board of Directors, and her great intellect is only eclipsed by her big heart for students, Prevention Point clients, and puppies. Jose Benitez is a graduate of our School of Social Work and Executive Director of Prevention Point Philadelphia. He is a tireless advocate for harm reduction and for communities affected by drug use. I have worked with this incredible man for over 5 years, and I have to say that I'm in awe of him every day. Jose is one of the finest professionals and human beings I have ever met. Brittany Applewhite is a program officer at Vital Strategies and seconded to the Philadelphia Department of Public Health's Department of Behavioral Health and Intellectual Disability Services, DBH-IDS. She is an experienced health professional with particular background in health disparity reduction and minority health. I have known Britt since she was a freshman at Temple, worked with her and taught her all 4 years here. She's a fabulous professional and an even better person. The best compliment I've ever had, actually from Jose Benitez, was that I must have trained her well because she was the best program analyst Prevention Point has ever had. David Malloy is the mobile services supervisor for Marikey. He supervises the team at the Police Assisted Diversion Program in Kensington. David is a tireless advocate for his clients and uses his personal experience to engage those around him. He's also really funny and easy to be around. We become fast friends, colleagues, and co-conspirators. Before turning the mic over to Dr. Bass, I would also like to extend my immense gratitude to Dr. Sandra Davis, chair of the DEI committee, for her vision and commitment to bringing our community this excellent programming.
Thanks so much for those introductions, Dina. And I also want to say that I too am a Temple owl. So I am a proud graduate of the public health program at Temple. I'm really happy to be part of this and to spend this hour talking about this important topic. Just a couple of housekeeping items first. We'll have about 15 minutes at the end of the panel to answer questions. So if you have questions, please put it in the Q&A feature instead of the chat to type those in. And you can do that at any time during the talk. So don't wait until the end. So if something triggers a question that we're talking about, please put it in there. Second, there will be a brief survey about the event. So a link to that will be posted in the chat at some point, probably in 30 minutes or so. Please just take a minute or so to do that. It's great to get that feedback and kind of continue to improve the types of events that we offer. Okay, so as Dina said, I have worked extensively with Prevention Point in research projects. I'm also the vice chair of the board. One of the projects that I'm currently doing is assessing the effect of COVID, both on people who have substance use disease, who are participants at Prevention Point, as well as the staff at Prevention Point. And we've done a series of qualitative interviews with participants and staff where we've specifically asked a question of the participants about their fentanyl use. So to kind of set this up before we get to our group, I want to kind of show you a typical quote that we have gotten so far from folks, just as a way to kind of drive, how problematic fentanyl has become. So let me pull that up here. Oops. So this is a female, she's 23 years old. And the question is just an open-ended question. Tell me a little bit about your experience with fentanyl in general. So it's my frenemy. It's picked me up when I'm down, but it put me down more. It's the only person that was ever there for me. When I cry, it pats me on my back, but when I'm done, they're pushing me down more. It took everything from me. I got a relationship with it, and then I tried to leave it and I can't. And now I'm just out there by myself and I can't stop. It's just so stressful because I don't want this lifestyle. Like I'm a whole nerd, like I'm really a nerd. I like just learning and going to school and stuff, but something happened. It just took me, like it grabbed me and it held me. It got me in a headlock. Like I'd be crying because I don't want to do it, but I can't help it. Like right now, I'm going through withdrawals on purpose because I'm really trying to like stop, but like I just can't. It's like, yo, it's the devil. Like those blue bags are like the devil himself on earth. I swear people will kill their own love for that little blue bag. Like the stuff I see that happened to me, you won't even believe it. Like for this little blue bag, it took everything from me. I'm a totally different girl. Like I don't even know who I am. So in thinking about that, I think, our first thing would be to talk with Jose. And because I think, Jose, you can really give some good insight into kind of how fentanyl especially has changed the illicit drug market in Philadelphia.
Yeah, so thank you, Dr. Bass. I mean, I think that we to sort of set the stage, and I think the comments that you read are clear around fentanyl changing everything, right? So if you look pre-fentanyl, when we were, when I first started at Prevention Point about 13 years ago, people was sort of when using heroin, but using heroin and injecting maybe up to 3 times a day, sometimes 4 at the max. And what happened when fentanyl got introduced into the illicit drug market, it really then became the common practice that people were sort of injecting 9 to 12 times a day, right? Because the half-life is shorter in fentanyl than it is in heroin. And so what happens is then you sort of have to deal with all of these associated, related implications that have with the increased number of times that a person's injecting, right? So first off, if you really look at it, and it put a lot of stress on all of our systems. It used to be that if you were trying to help someone to get into some kind of treatment program, and if it didn't work out, you could sort of say to people, come back tomorrow. Pre-fentanyl use, people might have come back tomorrow. Turning somebody away at that particular point now really does put them at higher risk of overdose and overdose death, because you are, sending someone back out on the street who will potentially use fentanyl and may use it, at a level that induces an overdose, and then we have an associated death, right? And if you really look at it, because it's the perfect storm, you know, what was happening pre-fentanyl was that there were a lot of opioid prescriptions out there, and folks were sort of getting opioids from their physicians at that particular point. And what's happening, you know, what happened was once everyone sort of started to figure out, wow, we're really overprescribing this stuff, and we're starting to see associated deaths with it, right? Or associated opioid use disorder, right? What we really started to do, and what states started to do, was clamp down on the number of prescriptions that were going out, right? So all of them set up monitoring systems basically to monitor how many scripts, how many opioid scripts doctors were prescribing and to whom they were prescribing it to, right? The issue with that then became that, you know, the opioid scripts were sort of dwindling down, and access to opioid in pill forms was sort of being denied to a lot of folks. And so what are you left with? You're left with buying opioids on the street. If you have opioid use disorder and a dependence, you're left with buying opioids on the street, either in pill form or in injectable forms, heroin, fentanyl at this particular point. And if you look at it, you know, what was happening was, you know, pill form opioids were kind of about $36 a pill on the street versus a $5 bag of heroin and or fentanyl, right? And so what are you going to do? I mean, just like, you know, it's basic economics, right? You're going to go for the $5 heroin hit, and that's sort of the use. And so we got a lot of folks that went through that transformation of using pill form to injecting. So much so that, you know, if you look at our syringe exchange program, about 4 or 5 years ago, we were at about 4,000 people. We are now serving 15,000 people in those short amount of those 4 years. So it's an increase of from 4,000 to over 15,000 people in those 4 years. And so what we've set up is this perfect storm, because, you know, our treatment, you know, our treatment programs are strained because you have a bunch of people coming in trying to access the treatment side of things. And it really is, and I know that we'll have other folks on the panel talk about the treatment piece, but it really is something that has put a strain on us. And we have to move in Philadelphia, and we have been moving. We've made great strides to trying to get treatment on demand, which is what the demand is. And then the last thing I'll say real quickly is that multiple injections at the rate that we're talking about, right? From 4 times a day to sometimes 12 times a day, what it really does is has associated health risk happening all the time. So soft tissue damage. So we're seeing an increase in the amount of wound care that we're providing to people, more frequent visits to the emergency room because of wound care, right? And so there are a lot of associated ills that come with the increase in the number of injections that people are providing. And I'll stop there.
I think too, Jose, one of the interesting things is that fentanyl is now bled into other types of drug supplies too,
That's
right?
right.
So we're
Yes.
seeing issues with cocaine, and some of the overdoses have been from that.
That's right. So that even with fentanyl is now so pervasive across the illicit drug market, right? When we first started, it was sort of relegated to injecting drugs, right? And you know, to heroin basically. But now we see it in, you know, it mixed in with marijuana. We see it mixed in with powdered cocaine. So there's other, there are other drugs where now fentanyl has sort of infiltrated the whole illicit drug market, which gives us something different to deal with.
Mhm. So I guess, the next interesting thing is that, this is happening all in the context of COVID, and the pandemic. So maybe talk a little bit to us about how COVID has now affected overdose death rates here in Philadelphia.
Well, we're about to see, so the final numbers aren't out for the year yet, but we probably will see an increase in the numbers of overdose deaths from the previous year. I think we will in 2020 we will exceed that number. I think this is really a challenging piece for public health professionals, right? Because when you really think about it, let's think about the mixed messages that we're sending out to populations that are actually at the highest risk, right? On the one hand, we have a pandemic where we're telling people, observe social distancing, right? Stay away from other people, right? Wear your mask. And then we have a public health message that we were sort of, educating folks on to use in groups, or you don't use by yourself. If you're going to use, don't use by yourself, right? Because we really needed someone to sort of be there with you, and we needed to teach people to observe an overdose and then do something about it, right? Introduce Narcan into that situation. And I think there are public health messages that really have people confused. And so what we're doing and what COVID did is sort of, I think, exacerbated that issue where we have a lot of folks who are using by themselves and are overdosing, and they're using a lot more privately, where, I think prior to COVID, people were sort of we're trying to adhere. We still had a problem that people were using by themselves, but it wasn't to the numbers that we're seeing now. And I think that the additional overdose deaths that we're seeing this year is a direct result of our messaging around COVID and how COVID forced people to sort of use drugs, illicit drugs, in communities.
And do you think, more overdoses happening in the home?
Yes,
because of that too.
That's what we're seeing, I think that's the driving force of it.
So how then has that kind of changed programming and how you're offering services at Prevention Point for people?
So I think, one of the things that we got forced to do quickly, right, was to move whatever services we can move outdoors, right? So, we're doing syringe exchange programs outdoors. We're feeding people, and I'll step up to the plate program outdoors, right? We were providing some street-based case management for a little while. Until, because we should all recall what happened 12 months ago, right? It's almost 12 months now. What happened 12 months ago, at the first 3 months, we were all in a panic because none of us really understood. It was kind of like the old days of HIV. None of us really understood what COVID was, how we were spreading it, right? And so we all took these precautions to lock everything down. And what we've learned in the meantime is that, we did a slow return to some face-to-face interactions, making sure that it's carefully monitored, making sure that we have enough room to space, enough barriers, plastic barriers between people, that we could get back to some face-to-face kinds of interactions. And that what we did was also, do like our medically assisted treatment program, have a lot more telemed going on. And so those are all the adjustments that we had to make. And I think that the system by and large had to make those adjustments as well. We were having folks going into treatment systems, and the treatment system were faced with the same challenges that we were.
So now that we're kind of in the vaccination mode, how do you foresee kind of vaccination of those who inject drugs or are experiencing homelessness or are?
Yeah, I think the best news that we have is that the J&J, the Johnson & Johnson vaccines are probably going to make it through the approval process today or tomorrow, as I understand it. The city will probably get batches of that fairly soon. I think within the next couple of weeks is sort of the rumor mill that we hear. I think that, you know, advocates like myself are advocating for the J&J vaccine is because it's one and done. And so we really can just vaccinate somebody, have them there the one time, and it be done without having a whole logistical nightmare of trying to track people down for the second dose, right? And that's not to say that we shouldn't use other vaccines in populations like this. It's to say that, you know, where populations are the most unstable, folks that are really living on the street and have no place to live, that probably is going to be our most effective chance to get vaccine into people's arms.
Great. So I want to switch to Brittany now. So Brittany, tell us a little bit about Vital Strategies as an organization, and then maybe a little bit about how it's responding to opioid use in Philadelphia.
Sure. Can everyone hear me?
Yep.
Okay. Well, Vital Strategies is a leading global public health organization and trusted partner of governments and civil society organizations around the world. We help governments strengthen their public health systems to contend with really important, if not the most important and difficult health challenges. And some of those leading global initiatives include cardiovascular health, air pollution and health, tobacco control, food policy, and prevent epidemics, to name a few. The overdose prevention program I work in is largely funded by Bloomberg Philanthropies, and it was incepted in November 2018 in response to the opiate crisis here in the US. And ironically, it's the company's first US-based initiative.
So you are seconded to the Philadelphia, it's not the public health department, it's
No,
DHIPS, right?
It's the Department of Behavioral and Intellectual Disability Services Unit. And specifically, I work in the Office of Addiction Services.
So can you explain kind of how that works? Like,
Sure. I'll give some of Vital Strategies' overall involvement in Pennsylvania, and then I'll skip to Philadelphia. So to combat the opiate crisis, Pennsylvania and Michigan states were the first partnering states that Vital Strategies worked with, and we have since expanded to New Jersey and Connecticut. Pennsylvania had 4,520 overdoses in 2019, which led to the decision to work specifically in this state. And in addition to those state totals, the city of Philadelphia has been nationally recognized as a hub, or it's also been called the heroin hub, as the city provides a destination connect between street substance users from as far as Baltimore all the way to New Jersey, New York. And like Jose said, we know opiates to be things like heroin, fentanyl, and prescription drugs. So what the work looks like here on the Vital side is we use a multi-tactical approach to combat overdose and drivers of the punishment for substance use. On the state level, we have seconded staff at the PA State Health Department and at the Department of Corrections. And on the local or city level, we have seconded staff like myself at DBHIDS and at the Office of Criminal Justice. And in addition to supplying talent or people to do great work in these departments, Vital Strategies also provides funding to the health department and other city departments on overdose prevention initiatives. And we also partner with leading organizations in the fight, like Prevention Point Philadelphia, which is my favorite org to collaborate with. But I think the biggest way to get folks to understand the overdose prevention unit at Vital Strategies is to understand the guiding principles of our work. And the first guiding principle is harm reduction. And we aim to support the reduction of drug-related health and social harms in a manner that is patient-centered and supportive, without coercion, without judgment. And also, this is important, without the requirement to cease or change drug use. And this looks like supporting initiatives like Safe House, 24-hour drop-in centers, seeking to innovate and expand syringe service programs or SSPs, to fund and advocate low threshold medical care, like the medical center at Prevention Point, and to overall just engage communities about substance use, what it is, to kind of break down the stigma. The second guiding principle is support, don't punish. We work against the criminalization and punishment, exclusion, and stigmatization of people who use drugs. And this looks like offering alternatives to arrest for drug-related charges, or reducing those social penalties that come about for drug-related offenses. The third guiding principle, and one that is really relevant to this talk today, is racial justice. So, you know, as panelists, we talked about, in order to make progress, we have to target racist policies that contribute to the detriment of Black and Brown communities impacted by drug policies. And this looks like centering Black and Latinx and Indigenous folks impacted by drug use policies and practices through their exclusion in leadership, through focused and responsive policies and practices. And, you know, really looking at how do we unwrap and reverse the harm caused by former drug crises. And, you know, the crack epidemic is an example. And it's really important to address how people of color experience the collateral consequences of drug use, criminalization, and stigma. And this includes mass criminalization and surveillance, things like loss of eligibility for public housing and public assistance, or even something as finite as access to medications that they need, right? And the final but not least guiding principle we use is health equity. And this looks like removing disparities related to gender, disability, sexuality, and geography, just maximizing and expanding treatment access to everyone, but especially communities that are most vulnerable.
That's great. So I think one of the things that we're using some language that we understand that maybe we should just make sure that our audience understands is the idea of low threshold
Sure.
and harm reduction, but also I think this idea of warm handoff, which was another thing we were going to talk a little bit about.
Sure. So the warm handoff program is my baby. I work specifically on the warm handoff program that is within the Office of Addiction Services. And a warm handoff is exactly what it sounds like. It's a warm transition of patients from one service to another service. And in Pennsylvania specifically, the Department of Drug and Alcohol, or we call them DDAP, they developed a program to directly transfer overdose survivors from the hospital emergency department to a drug treatment provider to improve a patient's prospect of recovery. And in this state specifically, warm handoff programs are within EDs, and they are divided by single county. We call them single county authorities, or SEAs. I work in the Philadelphia County one. To ensure program success, DDAP entered contractual agreements with PA SEAs with a 5-year grant agreement that establishes that an overdose survivor is a priority population and requires that all SEAs create a warm handoff policy. In Philadelphia EDs, the drivers of this program, the people who fuel it, are who we call certified recovery specialists. And they are CRSs for short. And these are staff who link patients who are experiencing overdose or who present in need of treatment. And for public health heads or public health folks, this model is what we call a peer model, as many of the CRSs have lived experience. And another important mention about the evolution of the Warm Handoff program is that it is not just for patients who are experiencing overdose anymore. Originally, it was designed for as an intervention for opiate overdose survivors or individuals showing signs of opiate withdrawal. But in 2017, the program was expanded to include any individual showing signs of substance use disorder who presents at a local hospital. And this is a good thing. It means that more and more patients are receiving warm handoffs from all departments within a hospital. And it will hopefully, and what we're seeing is that it extends the arms of treatment access and hopefully will destigmatize substance use in the hospital setting.
That's great. So kind of getting back to COVID, we talked a little bit about how COVID has affected Prevention Point, but I think it's important to kind of think about just how COVID has impacted just entry to treatment for people.
Right. Sure. So with COVID, every organization has had to pivot and figure out how to move. And we've also had to modify our linkage to treatment model a bit. The CRS model is still largely in effect in all of the hospital EDs, with the exception of some models that use clinical staff to provide linkages and follow-up. However, there is, due to COVID, there is an evolving mobile CRS model that is becoming increasingly popular. And a mobile CRS can provide Zoom call or telephone call follow-up with patients, or just meet patients where they physically are. And, you know, before CRSs were stationary in the hospital, they stayed there. But COVID has allowed us to reimagine what the CRS model looks like. Also, because DDAP collects a lot of information around refusals, we are beginning to look at how we can address or mitigate some of those challenges. And the mobile CRS model definitely provides supports to patients who are beginning to have the thoughts or feelings or beginning that first process, that first step in change, right? And, you know, COVID has allowed us to reimagine what the peer model looks like and provide common touch to communities that are feeling anxious or closed off to the world because of the pandemic. So.
Great. Thanks, Brittany.
Mm-hmm.
So now we move to David, because I think, you know, we've kind of talked about the overall issues. We've talked a little bit about how some of these have been integrated into health departments. And now from your perspective, David, in treatment, I think, again, you know, thinking about how COVID has exacerbated already existing service delivery issues, and then what has been done in the treatment realm to kind of address some of those things.
So, and thank you so much, Dr. Bass, and thank Brittany and Jose for their thoughts. So I honestly didn't know what to expect. I think I was very similar to what Jose had shared about, like, we didn't know, right? So like March happened, everything. I mean, literally, I work in a large, there's a lot of outpatient programs, methadone clinics. I mean, literally from one day to the next, we went from completely in-person groups to, like, literally in a day, telehealth, you know, and, you know, we had some staff that had been here 20, 30 years who, you know, weren't the greatest at computers. So it was quite the interesting switch. We all had to go to that position. And I think it's interesting to point out at the same time, the police completely pulled out of Kensington. There was no services happening. And like it was like the best way I can describe it is May 18th, which was the first day that I went back. You know, we came back down to Kensington. It was like, I didn't even recognize, like, it was like nothing I've ever seen. I'm an emotional, compassionate, very passionate about my job kind of person, but I've been doing this quite a while, since 2006. But I could, you know, with no shame, tell you guys that afternoon, getting in my car, it's tears streaming down my face. Like, I had never seen anything like that. What we were faced with, hospitals were diverting. So any assessment centers that were seeing people were diverting people. They weren't assessing them. So you had just countless gangs of people like looking for help, not being able to get it. You had the PUA money kind of flooding in. So you had a bunch of people leaving the rehabs against medical advice. So this is what we were faced with. And I'll preface what I'm about to say with, there was a politician years ago, his name's Rahm Emanuel, somebody in Illinois. I'm not the best with names or quotes, but I will say this. He said something along the lines of like, you never want a good crisis to go to waste. And what I mean by that is you're going to be able to do things during that time that you might not otherwise be able to do. And with that in my mind, through collaboration with various partners, Prevention Point being one of them, we kind of were like, what do we do? How do we make this work? And before you knew it, I ordered a couple blood pressure machines, a couple non-contact thermometers. I got samples of like what assessments look like from crisis centers. And for lack of better words, we created our own little mobile crisis center where we could get people assessed and placed. It's not a perfect system by any stretch of the imagination, but we were able to do this because of the circumstances we were in. All of a sudden, boom, we were starting to make a difference. You know, like all of a sudden we found something that works. The idea, you know, because, and this goes to what Jose was speaking about earlier, fentanyl, like it used to be, if you did a couple bags and you went to wherever you were going to get into somewhere for treatment, you're good for the day. So if it took 8, 10, 12 hours, you eat a little peanut butter and jelly, look at the little smiley faces on your slippers, while you're waiting for everything to go, like you're good. We were seeing people that came to our office at 8 o'clock in the morning, completely inebriated and impaired. But if they weren't placed by noon, they're gone. And that's the big challenge, I think, that COVID has put on the system. And it's not just us, it's hospitals. So you have people with the wound care that Jose and Brittany were talking about. They're going into the hospitals. They're treating them for the wound care. They don't have a full opportunity because you got that 4 to 6 hour window. If you don't get them stable on some kind of medication or get them comfortable, they're leaving. And, I can tell you firsthand experience down in Kensington, people when you talk to them and you look at their history, you're realizing like, man, this guy's been in the hospital 9 times in 14 days. And, then you start talking to some of the doctors in the area and they're like, yeah, man, we're doing more amputations than we've ever done ever. Because and when you really go back to the root cause of it, it's the driving force is that withdrawal. And it goes back to those kind of quotes that you were reading at the start, where people like, it's not a question. This isn't a moral question. People are not running out of the hospital against medical advice because they're bad people or they're making that choice. This is like how deep this whole fentanyl thing has got. And not to throw a monkey wrench in it, but I also think over these last several months, this new kind of thing with all the tranquilizer and xylazine, that's adding another realm to, what we have to deal with. And I think that's the importance of all of us. Because I was neat when we were talking right before this, I realized wow, we cover, each of us cover. It's like Jose hands off to Brittany, Brittany hands off to me. Like we're all coming at this from a different place, but we all need to be communicating because the situation that we're addressing is evolving almost by the day, if not the week or the month. So.
Can you talk about what treatment looks like for someone now? So if they have decided to go into treatment, the more standard pre-COVID would have been, coming inpatient, having in-person meetings, meeting with a therapist, et cetera. What does it look like for someone now?
It is, and it's a really, I'm glad you asked that. I'm full disclosure, and I'm very transparent about my past. I'm an individual that identifies as in long-term recovery. And one of the thoughts that I have almost daily right now is I couldn't imagine having to get sober or get clean now versus where I was at when it happened for me back in 2004. It is challenging. Addiction by nature is a lonely illness. I think like when you strip it all away, it's disconnectedness. It's you're separated from your family, separated from your belongings, separated from society. So I think conversely, recovery needs to be the opposite of that. But it's really hard to create that connectedness and being part of a community and the warmth of human interaction. People aren't getting that. So, it's like we have to be creative. I know at the methadone clinic, we had to basically create a room that was completely encased in plexiglass. And, we're blessed to have I call him the mad scientist, Dr. Bob, who's our medical director. He kind of created this thing with like a tattoo board so people could put their arm in, get their blood taken, all in a safe manner so that we could continue to do the face-to-face appointments, because with methadone being a Schedule II, you still need to see them face-to-face. So we had to create this environment to make that happen. As far as counseling, most of it is done through telehealth. I know for us, we're trying to move more away and into more virtual treatment to try to recreate as much as possible some of that connectedness. And then on the street level, and this is something that I've just noticed over the last several months, I'm noticing people that we engage physically, that we talk to face to face before we get them engaged in treatment, they seem to do a little better. And I would attribute some of that to the human connectedness. It's my sincere hope that as we move forward and more folks are vaccinated and there's more access, that we can kind of get back to getting with people and kind of reconnecting. Don't get me wrong, there's silver linings in all this. Like I said, I think the mobile assessments that we were able to do is opening up an opportunity for a lot of other places to do the same thing, because we have to cut down on the amount of time that it takes to get somebody admitted into treatment. And I think that was one of the big highlights that we were able to prove, was that, because on average, and I can't remember who did it, I think it was the DBH-IDS, they did a survey, like people where they kind of survey monkeyed everybody about what was your issues with access to treatment. And the number one complaint was like the time that it took at the crisis center. So, when you couple that with COVID and fentanyl, which lowers the withdrawal is happening within a couple hours, that is the reason why the AMA rates went so high. That's the reason why so many people were walking out of the crisis center. So, like I said, it's challenging, a lot of virtual stuff, a lot of telehealth appointments. And it's just a matter of like constant communication with other folks and kind of communicating about like how can we kind of move the needle a little bit more as we kind of go forward here as things.
I think that last question then is just kind of what are some of your thoughts about what's on the horizon as we kind of continue to deal with this epidemic, but also thinking kind of forward and transforming the way that we deliver treatment to people?
Well, I think, and it's funny because I feel like being on this panel is going to kind of cause Brittany to be bombarded by emails from me, because I feel like the hospital setting, a majority of the people that we see, and Jose can probably second me on this, it's hard to get them into a rehab because they have so many comorbid medical problems. Like, that's the number one thing that happens. You hear this all the time, right? People go to the emergency room or they go to the crisis center, and the crisis center says, we have to get you medically cleared before we, because whatever program is going to receive them is like, wait a minute, they have open festering wounds, they need liquid antibiotics, whatever. So the thought being, I think the warm handoff, the collaboration between hospital-based settings and treatment centers is going to be a huge piece of the puzzle in like how we can kind of not so much address it, but get a handle on it. Try to get some of the folks that have the highest level of need, try to get them needs like, in real time. Because I can tell you, that's what we're seeing. When I call to get their treatment histories, you're hearing, yeah, they were just discharged from this emergency room. They were at that emergency room last Tuesday. They were seen here on Thursday. There's a lot of that. And I think more hospitals using medication. Now, I'm not a medical professional by any stretch, but Suboxone can have its challenges with folks that are using fentanyl at high levels. It can create precipitated withdrawal. There are some kind of different things people are doing around macro and micro dosing, and there's a lot of like really fascinating studies that are happening, which is neat to see. But I think an immediate solution to that would be the utilization of more methadone at hospital-based settings. Methadone is something that will not cause withdrawal. And an interesting side note, purely anecdotal on my part, I don't see many folks dying of fatal overdoses that are dosing daily in a clinic, because it takes away one of the risk factors for an overdose because their tolerance is already up. So even if there is fentanyl use, it's just not something that I see on a regular. I do see a lot of people that walk off the clinic that happens to, because again, now there's no tolerance there. So I think that might be a good switch. And I want to tie into some of the criminal justice things that are happening where folks are in these police assisted diversion programs. And I had the pleasure of working with one of Brittany's counterparts in Vital Strategies around setting up these police assisted diversion programs and trying to like connect, instead of saying, all right, you're diverted, you're not getting arrested, but let's try to meet these needs while we have you in front of us. So in other words, again, this police assisted diversion model, it creates another access point where there's a lot of folks that there's a really high probability that they have substance use disorder, and we could potentially engage them. And it may not be that moment, that night when they're getting diverted from arrest where they say, hey, I need some help. But for lack of better words, we're getting our meat hooks on them. We're engaging with them. We're building a rapport with them. So maybe 2 weeks from now or 3 weeks from now, or, when they reach that moment where they're like, yeah, I need some help, they're turning to us for help. That is something that I see as like a next level kind of thing that's going to, again, reduce the length of time it takes us to get somebody into treatment. And it's going to put us in a position to reach that population that Brittany was speaking about, that's kind of been, kind of like had to bear the brunt of a lot of this stuff over the years.
Well, thank you, all three of you. That's great. I want to leave the last 10 minutes to answer some questions. We've gotten quite a few questions in the chat. So this could be for any of you to answer. Our first one was just asking about the COVID stimulus that was given to folks, and how to help people with substance use disorder not relapse or return to drugs or postpone rehab because of the sudden influx of cash through the stimulus. Anybody want to take that one?
I can touch on it a little bit. The really good thing about warm handoff is that the CRSs are able to follow patients for up to a year. So if at any point a patient is, receives a stimulus and is in that phase where if they are in recovery, the CRS is able to support them and help with any of those drivers that could result in relapse. If it means helping them find secure housing, helping them find food, helping them get connected to mental health resources. That's one way. That's what I could think of.
And in regards to like people that, I saw both sides of it. Like, don't get me wrong. I was getting calls from like all the rehabs that were like, everybody's leaving because they all knew that their money was hitting or whatever. But then there was another group of people that started showing up at the PAD office, and we kind of share this area with Prevention Point. So we would kind of collaborate. Somebody would walk over from Prevention Point and be like, hey, so-and-so's here. We would talk to him and realize he's coming to us saying, listen, this money's coming Friday. If I don't do something now, I'm going to be in a lot of trouble. So it was like two sides of it. And not for nothing, I almost feel like it worked for everybody. If that makes, like, in other words, there was definitely bed access for, and people were able to access treatment. And then some of the other folks who are now, we would see them like 2 weeks later when they were broke and they wanted to get help, and there was still better availability, so that we could get them the help as well. The other little piece of this that I want to touch on, and this goes to the disparity, the all the things were happening in Kensington. There was a lot of predatory stuff happening down there with that PUA money, and there was a lot of scam artists, and it really was a hurt piece for me personally, watching, people prey on an already kind of just vulnerable population, and they were getting preyed on even more. That was like one of the parts of this that was really kind of disheartening.
That actually is interesting because it goes to one of the next questions, which is this person says they're a Kensington resident. They've seen firsthand the impact of gentrification and real estate investors or predatory practices on people who have substance use disorder, as well as just displacement and homelessness of people, and that many get cash from investors, and within months you kind of see them on the street. So maybe talking a little bit about what are the policy implications and advocacy strategies to try and stop that in Kensington.
Well, I think that there, I know that the Inquirer just did a couple of Sundays ago a interesting article on the real estate situation in Kensington and the regentrification of it. I think, it's hard to say because I think, one of the things that I think all of the panelists have sort of, the theme that we all sort of have focused on is the fact that, what COVID did and the overall opioid use disorder epidemic did was to sort of like really strain systems that were already strained. And we have to one of the policy implications I think that we're seeing at this particular point is what's going to happen around gentrification in Kensington. There are already a lot of displaced folks here, and I don't know that we as a system have a good plan to address what's going to happen with all of these folks. And I think that eventually what will happen probably is that the community will get gentrified, people will get moved out, poorer folks will get moved out, and that, it'll move the problem to another community. And I think we have an opportunity to sort of try and figure out what we do about that as advocates now, as gentrifications is, sort of starting to come over the horizon, because it's just starting in Kensington. I think it's going to be really problematic, honestly.
Brittany, is that on Vital Strategies list of priorities at all, of trying to kind of think about policy implications for displacement of people who have SUD?
Can you repeat the question?
Just if Vital Strategies kind of has that piece on their their radar for an issue that might be affecting people who have SUD, especially in urban settings with the gentrification issue?
Right. That's a good question. So we don't have seconded staff in the Office of Housing Services at the moment, but I know that we RFP'd for funding opportunities for those organizations to assist with displaced Philadelphians, to expound upon drop-in services, and provide some sort of housing and lifestyle stability for folks who are experiencing substance use disorder, but specifically, indirectly, yes, but with
Got a
actual,
lot going on.
there is a lot going on. And at the state level, we are pushing, but at the very minor local level, not yet, I will say, not yet.
So we just have a couple minutes left. I just want to address one last question, which is kind of the support of harm reduction strategies. So, all of you are part of that fight.
Right.
And I think, one thing that people are interested in is Safe House and the support of Safe House. So maybe talking about the impact that a safe injection site might have on Philadelphia.
Well, unfortunately, I mean, I could tell you, unfortunately, the court decided, that right now it's something that legally we, can't be open, right? I mean, look, there's tons of experience around the world about these, right? And one of them is that what we found, study after study after study in different countries, is that where there's a safer consumption site, there's less use on the street, less litter associated, less paraphernalia associated on the street. And, they tend to be places where people access more services. It's sort of, so those are what all the studies tell us. Unfortunately, this is going to be an ongoing court battle that is, probably going to take quite a little bit of time now, as it goes through the appeals process.
And to your point, Jose, it's another piece that we are still working diligently on is SSPs, syringe service programs. Philadelphia Prevention Points program is just probably the most robust in the whole country. And Vital is working at the state level to ensure that SSPs like Prevention Points, Philly, Prevention Point Pittsburgh, are the model for what the country needs. So although we are delayed with Safe House and we're at a bit of a hiccup, it's important to celebrate the success of the SSP in Philly and how it definitely contributes to our harm reduction model, the one that we really believe in.
And I would just briefly say, I'm a, in lack of better words, I'm a long game kind of guy. And I really feel like the continued discussion with the community members will continue to increase buy-in, and I just think like we just got to be patient and we all kind of do our part in this larger, initiative that we're doing. And I feel like there's a community harm reduction that we can all engage in that will kind of like add to their buy-in in what we're all trying to do. That's just kind of the way I've always felt about it. I could go on like a 3-hour tirade about mistakes and people trying to, move too quickly or whatever. Like the long game is going to be the way to the end goal.
Well, we are right at the top of the hour, so we did well with our timing. I just wanted to remind everybody to do the survey, the quick survey. The link is in the chat. And I want to thank Jose and Brittany and David for your amazing insight, all the work that you're doing for people who have substance use disorder in Philadelphia, and to Dina and Sandra for this great opportunity to have this panel. So everybody have a good day, and thank you very much.